Welcome to this explainer. Today, we're tackling a total heavyweight in cardiac care. We are talking about the cardiac glycoside, Digoxin. Whether you're prepping for your pharmacology exams, getting ready to crush the NCLEX, or gearing up for clinical practice on the cardiac floor, mastering this specific drug is absolutely non-negotiable. Here's the reality of digoxin. It can literally whip a failing, exhausted heart right back into shape. It's a fantastic ally for your patients. But, and this is a massive but, its margin for error makes it one of the most dangerous and delicate medications you're ever going to handle on the floor. You have to respect it. And to respect it, well, you really need to understand exactly how it works. So, here's our game plan. We'll look at the heart's powerful ally, the rule of three, walking the toxic tightrope, risk factors for toxicity, and finally, the nurse's crucial role. Oh, and fun fact, this potent medicine actually comes from the beautiful but totally deadly foxglove plant. Let's get right into it. All right, kicking things off with Section 1, the heart's powerful ally. Let's see when this drug actually saves the day. We pull digoxin out when the heart is basically waving a white flag. It's usually in one of two desperate states. Either it's completely exhausted or it's beating totally out of control. Specifically, you're going to see it prescribed for patients dealing with heart failure and cardiogenic shock, where the pump is just essentially giving up, as well as for rapid, chaotic rhythms like atrial fibrillation and atrial flutter. In these scenarios, the heart desperately needs intervention to function. Moving right along to Section 2, the rule of three. These are the three core mechanism rules you absolutely need to commit to memory. First up is the positive inotropic effect. When you hear the word inotropic, I want you to immediately think of force. Because this effect is positive, it means digoxin forces that weak, failing heart to pump with much stronger, more robust contractions. If a patient is in heart failure, their heart is almost done. Getting it to pump harder is exactly the lifeline they need. Second, we've got the negative chronotropic effect. Think chrono like chronological, right? Meaning time. So we're talking about the actual rate of the heart. Since this effect is negative, the heart rate is going to slow down. That gives the heart more time to fill and rest between those newly strengthened beats. And third, the negative dromotropic effect. Dromotropic is all about the electrical wiring. A negative effect here simply means we're slowing down that electrical impulse as it travels through the AV node. This is a total game changer for getting chaotic rhythms like AFib and aflutter back under control. So put it all together and you get this delicate balance. We get a much stronger pump, absolutely. But the trade-off is a slower rate and a slower electrical impulse. Stronger, but slower. It's a fantastic combo for a failing heart, but slowing things down like that definitely comes with its own inherent risks. Which brings us perfectly to Section 3, walking the toxic tightrope. Because of how it alters those mechanics, this drug creates a really precarious situation. Now, this is absolutely crucial. Digoxin has an insanely narrow therapeutic range, 0.5 to 2 nanograms per milliliter. You really need to burn those numbers into your brain. That tiny window is the only place where digoxin is safe and effective. It's a razor-thin margin. You know, if it drops below 0.5, the drug isn't doing a thing. But if it creeps past 2.0, well, you've got a medical emergency on your hands. If those blood levels inch past that 2.0 mark, toxicity sets in fast, and you need to spot it immediately. It usually plays out on a timeline. It starts sneaky. Early on, the patient might just complain of nausea and a little vomiting. Honestly, that can easily be brushed off as a minor stomach bug if you aren't paying attention. But then they'll report bizarre vision changes, like seeing these yellowish-green halos around lights. If it gets to the late stages, you're looking at dangerous ECG changes and severe dysrhythmias. If your patient is on digoxin and any of this starts happening, you need to call for backup right away. Okay, Section 4, risk factors for toxicity. Knowing the symptoms is great, but we really need to know what pushes our patients over that toxic edge in the first place. So, what actually triggers this toxicity? The absolute biggest troublemakers here are electrolyte imbalances. A drop in potassium, hypokalemia, is incredibly dangerous and practically invites toxicity. But it's not just potassium. Low magnesium and high calcium can also act as triggers. Plus, elderly patients are naturally at a higher risk, as is anyone taking calcium channel blockers at the same time. You always have to look at the whole clinical picture. Now, even if your patient is sitting pretty right in that safe 0.5 to 2 range, you still have to watch out for standard side effects. The most common ones? Headaches and bradycardia. Remember that negative chronotropic effect we talked about? The heart is slowing down, so bradycardia is just this constant looming side effect we have to actively manage.
Let's bring it all home with Section 5, the nurse's crucial role. You are the last line of defense.
Because of that major bradycardia risk, you have got to count the apical pulse for a full minute before giving every single dose. And you must strictly follow the hold parameters. Always follow your hospital's specific protocols, of course, but generally you'll hold the med if the heart rate falls below 60 in an adult, 70 in a child, and 90 to 100 in an infant. You never, ever blindly give this drug without checking the pump first. But hey, the job doesn't stop at the stethoscope, right? Your ongoing role means aggressively monitoring their lab work, keeping a hawk's eye on those potassium levels. You need to watch their ECG for any subtle dysrhythmias. And on a practical level, make sure they're actually eating a diet rich in potassium or getting their ordered supplements, so those levels don't bottom out and start that deadly toxicity cascade. So we've walked the tightrope, looked at the mechanics, and covered the red flags. Now I'm going to leave you with this real-world scenario to test your gut. You walk into your adult patient's room. You check their apical pulse. It's 58. You check their morning labs. Their potassium is low. So do you administer the digoxin? Think about the physiological chain reaction that would follow, and let that guide your judgment. Thanks for joining me for this explainer, and keep mastering the floor.